I'm honored to be here, and this is a beautiful part of the world. I'm from Georgia, Macon, Georgia. I'm the incoming dean of the School of Medicine at Mercer University. I've been the only physician in my county, one of the poorer counties in Georgia, for 25 years, and I got into telehealth about 20 years ago, believe it or not, when I made the mistake of, in a public forum, saying this is ridiculous. The state of Georgia had spent $500,000 to put cable to my small town. I was the only doctor in town. $500,000 would have gotten me 5 more doctors in those days, and I was pretty mad about it. They gave us a telemedicine machine that looked like a Coke machine with a 7-inch screen, and we never used it. But a woman named Paula Guy, who ran the Georgia Partnership for Telehealth after I made my speech, came by to see me and said, "What is your problem? This is the future." And I didn't believe her then, but I do believe it now, and I believe that Mercer is a school that is committed to changing rural health in Georgia. And I believe that telehealth is the answer to that. I want to talk a little about what we're doing, but Georgia does, in many ways, lead the nation. We had the Georgia Partnership, which was a nonprofit that promoted telehealth for years before there was really technology that sufficed. The Southeast Region Technology Center is housed in their area. We have very strong reimbursement laws. In fact, the Insurance Commissioner had laws passed in Georgia to assure that any provider of insurance had to pay for telehealth long before there was telehealth. So we had strong reimbursement laws. We had a board of medicine that had to deal with people that came to the state because of our reimbursement laws that maybe didn't have the best interest of the people in mind. So we tried to write, I was on the Board of Medicine for a decade, was the medical director for several years. So we wrote rules in Georgia about telehealth that encouraged quality telehealth. We also got a lot of flack when community paramedicine came out, and every doctor in Georgia was filing complaints against the medical director of the EMS who was allowing these paramedics to go out and make clinical decisions. So we were in that. But Georgia is largely rural, and we're going to be number 50 in the nation in primary care doctors soon, so we're very underserved. But the one thing we had in every county, minus one of our 159 counties, was EMS. We had emergency medical services, so we felt we could use that and build it, and then we had the school. And right now, because Georgia did not expand Medicaid, our rural hospitals are closing rapidly. And so we're going to have, there are parts of Georgia that equate third world country status. So we're trying to come up with solutions for that. And I hope telehealth will work. I don't text and drive, but I did take that picture near Waycross while I was driving. But what Mercer was asked to help these areas. So we got the one county, Triggs County, Georgia, is the one county in Georgia with no EMS. Response time to the county is about an hour. So Mercer looked around, tried to find some partners, and we partnered with a federally qualified community health center and the regional hospital center in an adjoining county to design a project where the regional hospital will place an ambulance in the county. Now, that's huge for that county because it takes an hour to get there and sometimes that much time to get back to a hospital. But we've equipped that ambulance, or will equip that ambulance, with a telehealth bag that allows the ability to examine the patient. So while they're sitting in the county, if you're sick in the county, you can go to where the ambulance is housed. The EMTs are presenters. Our rules in Georgia allows anybody to be a presenter as long as they have some training. It can be a layperson, but the EMT we like because the paramedics are trained to know who's sick. So if the patient needs to be transported, they know that. But if the ambulance is in the county, the patient can come to the ambulance housing unit and be seen by a doctor in an urgent care center or emergency room. Now that bag that we've given these ambulances includes an otoscope, an ophthalmoscope, a Lippmann stethoscope, 12-lead EKG, and we have mobile X-ray, a digital film that can be done within the hour and returned to the physician. And then we worked on an area, and I'm going to talk a little more about the Hancock County initiative. Our first project is we're waiting for funding of a grant, but we feel pretty good about our grant. We too partnered with Verizon because of cell phone coverage is very poor in rural Georgia, but we've made the ambulances hotspots, so you have excellent transmission of the data. Hancock County is an unusual county in Georgia. It's a very, very poor county. In 1700s, it was one of the leading centers of agricultural research in the world, but now it is the end of the earth. It had no care. There were no providers, no physicians. We did some preliminary data in the county, and absolutely at least 68% and probably closer to 85% of the 911 calls were non-emergent. It did have an ambulance service, but as Jack alluded, EMTs are vary, and these guys are making $9 or less an hour. It was a private ambulance service. It was one ambulance. But we felt we could work with them and train them and provide them with telehealth capacity to help bring their skills up. The nearest hospital was 25 miles away, and that's a small hospital. It's a critical access hospital, but it did have an emergency room that was willing to partner with us. And we were able to partner with other regional players to build a project where every ambulance in that county would have a telehealth bag. And again, that bag it was completely made up of the high quality equipment, full screen, and the ambulance, when it pulled up at these rural homes, was a hotspot, so we could transmit through 4G connectivity to the emergency room. The patient could literally be examined by the emergency room doctor. We could do an EKG. We could do some point of care diagnostics, which is something that we really need to work on availability that would help. We could order an x-ray and have the x-ray people there to provide that report to the physician in the emergency room, or you could look at it digitally. But this was the county that we chose to do it in. Now, Hancock County had a federally qualified community health center that was open one day a week. And we partnered with them as well. We put a telehealth unit, trained their people, so that during the day, if somebody approached the ambulance with a minor problem or an urgent care problem, they could connect into the federally qualified community health center. And it also took some of the responsibility off of the emergency room physician, so that the patient could connect in during the day if they went to the home and the paramedic really did not feel they needed transport. Because of the 911 laws, we had to have them sign a refusal of transport. They could immediately do their assessment. That was put into the electronic medical record through a fax and scan system that we put into the ambulances, not electronic medical record, and they were treated from the federally qualified community health center. So now during the day, that FQHC is open 5 days a week in that county, and EMTs see patients daily in that county. During the day, they refer them to the FQHC. In the evening and weekends, they refer to the emergency room care. In Georgia, as I said, we get paid. We have approached Medicare about designating our ambulances as presentation sites, but the providers in Georgia are paid for their work. These are our goals for the Hancock project, was to enhance community emergency services. We're dealing with people who may drive a bulldozer Monday through Friday and be an EMT on Friday night. So by using this system, when they connect into a physician, it actually enhances their skills. Trust is there with EMTs in rural Georgia because they have been the only provider that you had. And people tend to think that they're doctors or they know a lot of things, and they do. So we didn't have to build trust. We had to build skill sets. So we've used this project to enhance their care. We wanted to decrease inappropriate transport because the county had one ambulance. And when the ambulance left the county, there was a round trip of about 60 miles to the hospital and back, and someone would have a real emergency and die. And we wanted to also provide support of treatment in transition during the time the patient was transported. We wanted to have urgent care services in the county because at 5 o'clock when the federally qualified community health center closed, there was no county care. And every patient that's seen by the EMT or paramedic when they go in gets an appointment with a primary care home. So when they leave, if something's accomplished, they're given an appointment with their doctor, who may be in an adjoining county, or the federally qualified community health center. And we wanted a sustainable business model because grants run out, and we didn't want to be grant funded. So that was our goal. Now, in the middle of this project, true to rural Georgia, the county commissioners got mad with the private ambulance service and fired them after we had installed our equipment, trained all their EMTs, gotten their skill and enthusiasm up for it. And Grady, out of Atlanta, which is about 130 miles away, decided they wanted to take over the county. Now, Grady had more sophisticated EMTs. Their emergency services were certainly a different level than the first service, but they did not know anything about telehealth in primary care or telehealth in a rural area. And their average transport time in Atlanta was less than 5 miles. And here they were in rural Georgia, and it was 60 miles, and they had one ambulance, but they managed to get another ambulance. And we've worked through that problem, and I think it made us stop our project, regroup, and so our data is still lacking, but we're beginning to get them up to speed. And I think we'll have better data when we finish this. Certainly we have better trained personnel, but they're helping us grow that primary care home. But the first phase of this project was to try to enhance care in the county. The second phase is when everybody in this county that's hospitalized leaves the county. And so very commonly their readmission rate is quite high because, you go to the hospital, you're sent home, there's nobody there, their children live in Atlanta. These are primarily older and poor people. There's one drugstore in the county that's part-time, so there may not be a place to fill their prescriptions. So after discharge from the hospital, the social worker who discharges, or the physician who discharges the patient, makes an appointment with the paramedics to go back out and see that patient the second day. So they'll go by the house if they have time, and if they don't, we'll make arrangements for a volunteer or first responder to go out and visit with the patient and connect them in either to the discharging doctor or to their primary care doctor or to the FQHC. And then we're going to try to address the high maintenance people, the people that come back a lot. These are our goals: to increase access, to improve quality of emergency services, to evaluate and treat without transfer, to decrease the inappropriate utilization of services, to decrease non-emergent transportation. Every one of you know how people use an ambulance service to be transported when they don't need the services of an EMS or an emergency room, but there's no other care. It's easy to be judgmental about, but when you don't even have a car or no way to go, and the ambulance will come get you and take you there. So we have found that patients love the service, similar to what you said. They're very receptive to it. And they're very proud that they see a physician, and it builds trust in that care system, so they stay local and they develop care locally as well. And we want to improve chronic disease management. These are the data points we're collecting. That is a real sign. I saw it down in South Georgia. We want to look at utilization. We want to decrease what we think is inappropriate. We want to save money. You can talk all you want about getting payers to pay for these services. They're not going to pay for them until we can do a project that shows we save money. So we want the data to go to these payers. And we actually got approval from one of our managed Medicare providers who has the most of that county to pay our ambulance service and to pay for the visits. Of course, they had to pay for the visits because of the rules in Georgia, but they didn't have to pay the EMTs, but they do. We wanted patient acceptance, which we've gotten, and we wanted physician acceptance. We wanted the physicians to like it. Now, one of the problems we found was we were using if you ever been to Georgia, and if you ever been to Lake Oconee, it's a fancy place, part of Georgia, it's near Hancock County. And a lot of Atlanta doctors who were successful and retired to Lake Oconee and then ran out of money, decided they wanted to work a little at this critical access hospital. So we went in and we trained them about telehealth, and they'd say, "Oh, I've got it, doc. I know this stuff fine." We'd call in and they'd go, "I ain't got time for that. I'm not going to do that." Bring them on in. That happened repeatedly until we went back and realized that these older guys didn't have a clue what we were talking about and wouldn't tell us. So we had to finally get a nurse who we could train to be a champion and let that nurse every day retrain those older doctors that came in. And they do a great job with it. We got an institutional acceptance, which is a challenge. And as Kathleen said, I had one of the financial guys at the big regional medical center tell me last week, "Dr. Sumner, if we take that patient with bronchitis to the emergency room, we get paid $300. You're offering us $30 to see him in the home. $30 is the presentation site fee." That's the point. But if you'll just give me time, I'll show you how I save you money, because you're not getting paid for that patient in the emergency room either. And we wanted to build the infrastructure. These are our challenges. Reimbursement is a challenge, huge challenge. We've got to change that. You can't say that you want to decrease rehospitalization rate and not put something out there in the community to help sustain that. And you've got to get reimbursement through data. You've got to have the data to give these payers to say, you're insane. You're paying $300 to transport a patient to the emergency room. In the state of Georgia, that same emergency room, if you call non-emergent transport, it's $400 to take them back home. So you don't want to pay our EMTs to go see the person at home, but you'll pay one of these vans to come and $400 to drive them back home? Give me a break. Just pay the EMTs $100 a visit. We'll take that. We'll save you money, but we've got to prove that. Leadership in politics. One thing you'll know is if you go, and I have had the opportunity to go around the country talking a little about telehealth. Depending on the group, most people don't have a clue what you're talking about. They think it's a telephone, they think it's a telephone call. They don't know that you can examine the patient. You can literally I have a picture on my iPhone of a friend of mine that worked for the Georgia Partnership who was on the Altamaha River in Georgia fishing, and his ear started hurting. So he took out his little kit that he had with him, looked in his ear, and sent me a picture of his eardrum that had a bug plastered on it. The quality of that picture, the color of that picture was superb. But I was in a group of deans of medical schools about 6 months ago, and they were discussing telemedicine, and the complete consensus in the room was, it'll never happen. And you go, how can you be so out of touch? We have got to bring academic medicine and political people up to speed on what we can do, because if we don't, it will run over us. As providers, we need to control it and drive it and make sure we protect our patients and make sure there's quality and safety, but we have to educate them too. Physicians still feel that way, and 911 rules are somewhat archaic, that you require transport. We need to address that. What we've done is changed our triage system. There's a toll-free number you can call that's non-emergent. When you don't think you're that sick, but you need somebody to come, you can call that number. Otherwise, if you call 911 and the paramedics don't feel you need transport, with your permission, we can treat you in the home. Workforce development, telehealth helps to build skill sets in the providers on the ground. We provide quality care. I don't want to be associated with anything that provides a substandard product, but we do provide a quality product, and we also enable the right care at the right hospital. I can give you a number of stories, as these presenters have, about a patient who was taken to the wrong hospital with a stroke that had no ability to intervene, or a patient who cut off his fingers was taken to 3 hospitals before they found a hospital with a surgeon. We need data to change payers, and we need sustainable systems to replicate. One thing that we have to, if you ever look for point-of-care diagnostics, one of the things that would be tremendously helpful is to do bedside diagnostics, finger prick beam, electrolytes, finger stick white count, finger stick hemoglobin, that would add information to the physician that was treating that patient. Those things are available in third world countries. If you ever go on some of the sites from some of the providers and declare you're not an American citizen, I'm sure they're coming to get me, because I've declared that a few times, to see what's out there. It's amazing what's available in other countries. We need to bring that technology home. Abbott has an iStat, which is nice, but it's expensive. In some of the countries, there's a little credit card, you prick your finger and it does electrolytes. We need to get that home for our country too, so that we can provide some of that care effectively at home. Thank you.